This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Sam Robinson, and I'm pleased to have with us tonight Dr. Sami Walid, who is the Chief of Research at the Georgia Neurosurgical Institute. Thank you for coming. Thank you for coming, Dr. Walid. And so tonight we're just going to launch into a discussion about one of our favorite topics here, and that's trying to find a way to reduce healthcare costs. And I think as we consider the world these days, Sami, the whole country really, in our state of welfare is being impinged upon by escalating healthcare costs. Mm-hmm. And we've made some efforts to make some comments on that to see what can be done about it. If you look in the future and consider how expensive things are, we're not going to be able to continue to have enough money for Medicare or Medicaid, and the insurance premiums for people that have private insurance will just become unaffordable. And the expenses will be so extraordinary that it will really break the nation's bank. We won't be able to maintain the power of our currency. It'll be a disaster for the whole world. So it's a big deal. And maybe it's worthwhile to make some comments about that. Yes. So I think we have some slides here. We might just show our first one, which shows the unsustainable. Well, that's a rather good one there. And this shows our total national health care bill. So it's just an absolutely something that's going up year by year. And it's really over $2 trillion a year that we spend on health care. And finding a way to be efficient with that is a big deal. So that's enough for that slide. And let's flip back and we can see Dr. Walid here. Now, Sami, can you talk about there's some of the work we've done on looking into the information that that physicians have about cost? Any comments about that?
Yeah, we looked on to what extent the cost is included in randomized controlled trials, which constitute level 1 evidence in clinical science, and it was not very impressive. As you see, the increase in healthcare costs is exponential. It's not linear, it's not shallow, and this requires alertness to the seriousness of this issue and how it may affect national stability and security.
That's right. And so one of the things that basically what Sami's making reference to is that in medical literature, there's something called an outcome analysis when physicians decide whether or not they've done the right thing in a particular kind of treatment modality. And in that outcome analysis, it's not common to pay any attention to cost. Yes, and we'll maybe show some slides and just make some comments about that. The other thing we've looked into, have we not? Ah, here we go. I think one has appeared here. Well, we can make some comments about this. One of the things that we've done is to look into, in general, all of the literature involved with neurosurgery. This sounds complicated, but there's something called PubMed, and it's an extraordinary search engine. This is one of the tools that appears now that we can make use of. We can look at all the literature that's ever been published in neurosurgery that's appeared on PubMed, and then we can see what kind of literature there is. And what we'd like to see, if we can go back to the slide we just showed, and we'll see if we can do that. This shows basically over a 14-year period all of the articles that we could find published in English that were involved neurosurgery, and there were about 16,000 of them. And then we wanted to see how good the literature was. The next column there shows about 4,000 papers that just talked about case reports or case series. And and we flipped to the next one, but just go back to the other slide, and let's do that. We'll stay there a little bit. As we go down, we can see that at the very, very end of this, there are 40 neurosurgical blinded randomized control studies. Now that's the gold standard of great clinical data. So that's the kind of clinical data we'd like to have. And then if we could have that kind of clinical data, then we could really make some kind of really strong statements about the right thing to do for patient management and patient care. And also we could do something about cost. So let's see our next slide then, as long as we're here. And this shows basically what's happened over the past 14 years. And we can see that there are lots and lots of papers out there that are just neurosurgical papers. And the lines at the bottom show high quality papers. So we're not getting in our national literature, we're not getting high quality research that we need to empower physicians to do the right thing to treat people. So that's really some important things to say. And we're going full steam ahead on that, are we not, Sami? Yes. Trying to discover what some of the issues are. In general, just to explain this to the public, causality is a very difficult thing to discern. For instance, if someone has cancer and there are different kinds of drugs, there's a drug A and a drug B, which drug is going to be the best for that patient? And the difficulty is that patients have different stages of the disease, they have different risk factors. So to determine whether drug A or B is going to work, we have to make sure the patient populations are as close as possible. So we want people that are 59 years old that have one kidney and their lung function is a certain level. They've had the disease for a certain length of time. And so to really come to a good conclusion, we'd like to link all those patients and put them in one major treatment group. And to do that, it's often necessary to get multiple centers involved. So getting this big study put together is difficult, but once all those patients are in the hopper, then what can happen is there can be an effort to randomize these patients. So we're going to just arbitrarily say, you get drug X and you get drug Y, just by totally shake of the dice. And then what happens, the patients are followed along in this randomized control fashion. And the doctors that are treating these patients are blinded as to what kind of medicine the individual patient received. And at the end of this study, after a certain amount of time has passed, then the people that have conducted this study can say drug X worked better than drug Y. Now that's the gold standard of medical research. And so what the slides we showed earlier, that indicates that not too many of those studies are done, and there are reasons for that. Number one is they're pretty expensive to do. It requires a lot of effort. And the second reason is that we have to be ethical about putting patients in these trials. So it's not ethical to put a patient in a trial if it appears that we feel strongly that a particular drug would be beneficial beforehand. So it's hard to it's hard to conduct these studies. But one of the difficulties that happens with the tremendous amount of money that we have that being spent on medicine is the funding sources for these really superior kind of studies are not powerful. So it's difficult to get the kind of money that's needed to do this kind of research. But this is the kind of research that's needed to drive healthcare forward. So if we look at there are not so many papers out there that address these issues. And the best possible kind of thing would be to have some cost analysis put in the paper as well. Well, that was sort of a little trip down that road. Maybe we can show our next slide and we'll see what else we can discuss. And this basically, we can look at, it's an example of different kinds of neurosurgical procedures, and these are hospital costs. And the ones at the bottom are pretty classical neurosurgical procedures. They're just operating on brain tumors and clipping aneurysms and maybe doing simple discectomies. But I think we can see in the audience the curve that's going up in a very almost exponential fashion, or the amount of money being spent on spinal fusion. So we'll just maybe discuss this a little bit. Let's see our next slide, please. And well, we'll talk about that a little bit, Sami. Maybe these slides are out of order. I guess we have to deal with it. But this goes back to this is the different kinds of papers that we have in neurosurgery that address cost. And here we can see that we have 4 types, I guess we could say, neurosurgical case reports. And the costs are not in there any more than 5 or 6% of the time, which is that's not a very good thing in these high quality studies. And let's see our next slide, please. And this just shows the relative small number of randomized controlled studies that have cost in there. There are very few. That's the bottom graph, bottom line of the graph. And next slide. We're almost finished here. Next slide. And this goes back to the slide that we saw that showed that we had a lot of spinal fusion expenses going on. And what we'd like to do is we'd like to say, well, look at all that money that's being spent, about $30 billion extra dollars. We'd like to be able to say that as this money is being spent, that we're able to make determinations about what the right thing to do is. And the way that is done in medicine is we look at we put something called clinical guidelines together. And that's a big deal. So all of the literature that's out there, there are experts that come together and they say, this is the clinical guideline this is what we recommend that you do. And so we showed the example of the cost of spinal fusions, for instance, increasing a lot. And it actually, the hospital costs have gone up about $30 billion. So we'd like to have some guidance for physicians to be able to say, what's the best thing to do? But there's an absence of really good clinical data, and that's what the last slide showed. People have gone through and they just have not been able to find powerful papers to give appropriate guidance to physicians. So this is a very substantial problem, is it not, Sami?
Yes, yes, Dr. Robinson. Clinical evidence is necessary, is very essential in American reality because the American society is built on logic, science, checks and balances, and in healthcare you have to make clinical decision. Clinical decision in medical cases, you have to abide by government regulations, you have practice guidelines, you have insurance arrangements. Sometimes you are required to be present in tort cases. So all these factors require solid evidence, solid scientific evidence, and anything other than that is called anecdotal evidence, which cannot be used in an official institution or in an official debate, like in a malpractice case. So clinical evidence is like a pyramid; it's very steady.
Yes.
You have the top of the pyramid, which is level 1 evidence. This is the pearl at the top, and you have the more you have elements missing from important elements missing from clinical trials, the level of evidence is degraded, and it becomes level 2 if there is no randomization, for example. If there is no control group, it becomes level 3 and maybe less. So the process of clinical investigations requires a lot of rigorous organization, and that's why it requires resources, funding, and it's hard to do. It's like and whatever is hard to do, whatever is hard to find is expensive, like gold, like gems, and for example, in order to have a study pass FDA approval, hundreds of thousands and sometimes millions of dollars need to be spent in order to get FDA approval for a device or a new drug, and after that, we cannot be surprised why a medication is expensive or a certain procedure that requires instrumentation is expensive. Well, this is America, and we do everything with quality, and that's why the healthcare cost is increasing exponentially. Knowledge is increasing exponentially. Technology is increasing exponentially. The population itself is increasing exponentially. The population not only of USA, the whole world, and it's a normal reflection of the reality that healthcare expenses are increasing rapidly, and this is healthy. We're human beings, and it's the best way to invest your money in is human life, human health.
That's correct. That's correct, Sami. So really, in sort of what we're backing into in our little conversation tonight is the fact there's the absence of a lot of compelling evidence to make medical decisions. So a lot of this is left in the judgment of the individual physician, and causality is very difficult to say yes or no. So a lot of this is an art in regards to medical treatment between the physician and his patient, and trying to come up with the best decision. The guidance that research gives us is not as compelling as at first it might seem. And one of the issues going on now is that with the new plan, healthcare reform in the country, there's the idea of having a super panel. I think there are going to be 15 people on this super panel, and they're going to be in the position to really make huge medical decisions about what the government will or will not pay for. And this is going to be a big deal because they may not have the appropriate evidence to make these decisions. It's very complicated. And if the country doesn't get this right, there could be some major problems that would occur. And there's an argument to, in many ways, keep the decision making in a more local arena, and then find ways to basically upgrade the kind of medical evidence that's being produced these days. Now, people have been making medical decisions for how many thousands of years, 10,000 years. People make decisions about what the right thing there is to do to treat people that have medical difficulties. And classically, what happened, particularly in neurosurgery, is something called expert validation. So what that means is, we'll go back to the time of Harvey Cushing, who was this tremendous neurosurgeon that practiced at Harvard, and we could say he was the grandfather of all contemporary neurosurgery. And he would say, this is the way to do it. And then everyone that he trained would do it that way, and it became part of the custom. And so if one is doing a particular kind of operation, the idea is, how do the experts do that operation, and that's the right way. And the difficulty is that many of these, customs were not appropriately scientifically assessed, and having a very high quality evidence to say yes or no, is this the right thing to do? So the tendency has been over the past 20 years or so to have evidence-based medicine determine what goes on. And there's a major effort. This is not something that the medical establishment is asleep on. Everyone is trying to get higher quality papers and get more compelling evidence. The difficulty that occurs time and time again is that causality is so complicated. So it's relatively simple, shall we say, if a bone in the foot is broken. One medical event occurs, and the idea is we're going to say, what's the right way to fix the bone? And that's pretty simple, but medicine is generally not like that. There might be a person that has a diabetic person with vision difficulties, that has head trauma, that also has heart problems, that takes a lot of different kinds of medicine. And so putting all those variables on board in this clinical decision making is extremely difficult. The other thing, and I guess we'll just use this word for the audience, is something called comorbid morbidity. So what happens is when there's a particular kind of disease process, there are many other things that go along with that disease, and that makes outcome analysis very difficult. So the whole situation is extremely tricky and hard to come to grips with. The other thing that you alluded to a little bit, Sami, is the role of the FDA in approving different kinds of treatments and different kinds of medicine. And occasionally in the press, we can see comments about that. Many times a new medicine that might be useful, shall we say, to treat cancer is out there. Trials have been conducted, and there's a very rigorous way these trials are conducted. So the idea is to get the highest possible quality of evidence to say, yes, this will help people. And the FDA generally does a pretty good job with this, but they often can delay progress, and there are lots of difficulties attached with that. Many times the Europeans seem to go a little faster, so a common frustrating thing for American physicians is there might be a really good treatment of a new drug that is legal in Europe, but it has not received FDA approval here, and thus the drug cannot be used. That's some of the problems that confront physician decision makers about the right thing to do, and it all comes back to the evidence that's out there, and the slides that we showed just en passant a little earlier illustrate that, and we can hope the evidence improves. Another issue that we sort of touched on tonight, Sami, is the idea of standards of care and clinical guidelines. And these are two terms the audience might hear more about. The standards of care, that's really sort of a legal term, and it came out of a tort law. And the idea is there's something that's a very rigorous, bright line, and that if medicine is not practiced that way, then it's prima facie illegal practice. I mean, there's malpractice one could be accused of malpractice for not doing that. Something a little bit lesser than that are standards of care, which is a medical term, and it's a much softer turn of phrase. And the idea, these are suggestions about how to practice. And the problem is that both those terms are very hazy. They're very hazy concepts, and they change. There's no one that really propagates these particular concepts. And I think we spoke a little bit, did we not, Sami, about some of the work done on spinal fusions in 2005. Right?
Yes, the last slide is very informative, if we can show it again. It shows, it's a summary of a very diligent work by a panel of authors that represent the Congress of Neurological Surgeons and American Association of Neurological Surgeons, and headed by Resnick.
Dr. Resnick.
Dr. Resnick and co-authors. And all these columns represent individual papers that summarized a collection of clinical evidence related to a certain variant of spine fusion or a certain adjunct procedure to spine fusion. And as we see here, the green color represents level 3 evidence, and the red.
No, that's bad evidence. That's evidence that's not that good.
It's still good. It's better than anecdotal evidence. So it's still scientific evidence. It's not as rigorous as level 1 evidence, but as we see, most of the best evidence is related to common spine fusion procedures, especially regarding the use of instrumentation, and which is very important. And of course, more work is needed to improve the available evidence. But I think this is a reflection of the difficulties encountered by clinical investigators to apply their innovations to real practice. And what we have is below optimal, but we can do better. And
well, that's good,
we're
Sami.
hoping
That's
for
good.
that, yeah.
So, you know, I think the comment, and we can maybe just flip back, the comment there is the green. That was not really, those papers were not as I guess, scientific as we would like them. And there are very few papers that's on different important concepts that really give appropriate guidance. So much of the decision making is left to the individual physician and the patient about the right thing to do. And really, we'd like to get some clarification with this. We'd like some better papers, and we'd like to pay some attention to cost analysis to understand what's going on. And that's really a major thing that needs to happen in the country. Physicians need to understand what things cost. They need to have the statistics in front of them, and then they need to make efforts to diminish those expenses. That's a very complicated thing, isn't it? And these expanding costs are just not sustainable. We can say, and I think you've alluded to this a little bit, Sami, the benefits that are obtained in the American healthcare system are something that are not so commonly talked about. And many times you may hear the stories about the idea that the U.S. statistics are compared with statistics in another country and they're not so good. But what's not considered is the patient compliance to taking the right medications, the patients often making bad life decisions about, particularly in regards to obesity, diabetes, lots of things that are not discounted in those statistics. But where the statistics are appropriate, where they have an equal population that are taking the same kind of medicines, doing the same thing, particularly I think with cancer statistics, these show up quite well. There's very substantial advantages that occur in the United States. Additionally, other statistics that are not put in before the public are the degree of absence of morbidity that happens in our patient population. So we have lots and lots of people that are vigorous in their 70s, enjoying life, and that's something that's changed a lot. If one goes back and looks at the situation a generation or two ago in the United States, people were, their life expectancies were much shorter, their level of disability was much greater in old age, and it's really been very substantial improvement. And I think the people need to understand the system has produced that. And as we try and reform the system to make it more cost effective, all the good things that have occurred should not be discarded. And I think it's right now in America, I think we have to be extremely careful of giving politicians or a system too much power over individual patient choices that they need to make with their physician about what the right thing for them is. And that's something that physicians need to stand up for, and hopefully we'll do that here. And we'll try and make a difference in this national debate, because I don't think we can say how it's going to turn out, Sami. We just can't, if we try and speculate what the American healthcare system is going to be like in 5 years, it's just about impossible to make any kind of prediction. Now, Sami, I'm going to let you say one sentence now because we're almost out of time. Is there anything, you have any comment here about any of this? Make it 2 sentences.
From my experience with the healthcare system in the United States, I can say one word: the American healthcare system is merciful, and this is the best word I can describe the American healthcare system.
Well, that's a nice thing to say, Sami. That's a very,
all the parts taking participating in the healthcare system are doing their best to make the patient happy, and the doctors, from their part, are not sleeping nights, are wearing their nerves in order to serve their patients, and the health insurance is doing their best to cover the patients, and the hospitals are doing their best to improve excellence in their work. So I can say that there's no better than the American healthcare system.
Thank you. And well, we'll just continue our conversations, and we're going to keep going with our inquiries. And Sami, keep up your good work and looking into these issues. And so we'll have another conversation another time. Thank you for coming.
Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.